I am honored to introduce our marketing chair, Ms. Joyce Miller. She is also a past president of the CSOHIMSS chapter. She's going to be serving as moderator today, and she'll introduce our panel.
Thanks, Scott. First of all, I just want to say that if you're not in here, get in here, because this is going to be the best session of the day. So run out and get everybody who's left. But no, I've had the opportunity to do this and a couple times now, and I really want to make it more like a conversation. So after a couple questions, we'll take maybe one or two questions, because the last time we had people standing at the mic at the end of the day and we didn't get to everybody. So just want to make sure we get to everyone's questions. But what a culmination of great information we had today. I think we've touched on so many things related to population health, the analysis and the data piece, and yet there's always so much more to talk about. And today we have three distinguished people. So we'll start with Gary Ginter. I've worked with Gary on the board of CSOHIMSS now for about 8 years. And Gary is the vice president of Premier Health, and he's been with them for 30 years. And he's over all 6 hospitals, and he led the implementation of Epic a couple years ago. About how many now? 2006, so almost, you're at almost your 9-year mark, and so it's very exciting to have him here because he certainly has a lot of experience. And then we have Andy Lehman, and he is from Kettering, and he is the senior vice president. And today you got to hear one of his staff people speak, Steve Morrill, and I got to tell you, every time I've gone to any kind of presentation on data and public health, they're always talking up here, okay? And I thought Steve broke it down, thank you, at the very level of how to build that great program that you might want to do in your organization. And but Mr. Lehman is over all of the analytics, over population health strategies, and he's doing the Intel processes and the Lean initiative at his organization. And he has his certification in project management. And then lastly, this is a little different than we've had. We've always usually had either 3 CIOs, 3 CMIOs, but we have a biostatistician with us today. And so I was kind of excited to get to meet him. And this is Mr. Strauss, Warren Strauss, and he has been a biostatistician for over 20 years. And he has looked and studied statistics and mathematical design around environmental health, medicine, and toxicology. And he is at Battelle, where he has an organization that reports through him, 140 research staff with a budget of $30 million to look at advanced analytics and health research. So I think we have a great diverse group today. So we're going to start off with the basics, though. And so I would like to start with, and Warren, you may not have an answer on this one, but you can always jump in. But just really quick, we kind of wanted to do a quick review on ICD-10, since it just went in live in October 1st. And I put on the paper, does anybody really have anything they'd like to add now about ICD-10 after 3 or 4 years of conversation about it, how it went, the implementation, is it going smoothly? So,
and I don't know if Andy and I were talking about this last week at the conference, but it kind of had a feel of Y2K to it. There's a lot of work that went into it, but it was pretty much a non-event on October 1st. We had a command center all set up, and I think we disbanded it by October 6th, and I think to date we had 35 total issues. Now, the real meat, hits the road now with the, are we going to get paid from the payers? And we are seeing payment come back in, but it was pretty much a non-event.
Yeah, so to echo Gary's comments, as I viewed ICD-10, I always sort of broke it down into 2 big components. One was the IT component, and one was the rev cycle component. And once again, the IT component couldn't have gone better in terms of any issues we had. Thank you, Lisa Shivers, for all of that. And the rev cycle, we're still sort of waiting to see. I think from a coder productivity, standpoint, it looks like we have lost a little productivity with our coders, who are the ones actually, trying to submit the claims and do all the stuff to get the cash to come in the door, just because it's more complicated. And it appears that the majority of the loss of productivity is occurring in the ambulatory space as opposed to the inpatient, which is just kind of interesting. So we're going to just sort of have to wait and see what the cash flow looks like over the next few months. We have certain projections on what we think that's going to look like by the end of the year, and if everything stays as planned, I think it's very similar to Y2K. It's a lot of effort, a lot of thought, but in essence, it's hopefully a non-event.
So I'm a researcher, as was described, and so from my perspective, I'm glad to hear it's been a non-event in terms of the Y2K element of it. From a research perspective, Battelle has been involved in working with ARC and CMS on developing and implementing quality measures. And from a certain perspective, ICD-10 gives us a lot more specificity in terms of what types of conditions patients have and what types of procedural events are happening in the care setting. And so I think that will actually help advance the science of quality measurement and get to better models, more accurate models.
So you can kick this one off. With all the things we've talked about today, I was doing some lookup just on population health. Where are we right now? And some of the things I saw, it said the U.S. has the best sick care, not chronic care system in the world, high-tech, complex care, heavily hospital and specialty-based, very costly. But our population isn't healthy. And, so as we look at this, even Gary and I were talking this morning, when you may be talking from a health system perspective, you're really looking at your patients that walk through your door and you've seen. But how do you define population health management?
That's a really good question. So, I'm a public health researcher, and so the first time I actually encountered something that I think is similar to population health was very early in my career when I was a graduate student in Maryland, and I was working on a childhood lead poisoning prevention project. And we were trying to develop measures of risk at the geographic level and how that risk of childhood lead poisoning was changing over time as a function of geography. And so we took surveillance data, so this is your typical registry data. This is well before electronic health records were around. And we geocoded those records, and we tried to link them to different measurements in the census data, different investments that CDC and HUD were making into different communities, different information sources in terms of environmental data sources where they were finding lead from industry. And so from my perspective, population health is well beyond what happens in the clinical setting, because patients spend most of their life outside of the hospital or outside of their doctor's office. And so there's so many things that go on. And when we were visiting kids' homes, we were seeing childhood lead poisoning is an absolutely awful, horrendous thing. But when we were going into these high-risk neighborhoods, these neighborhoods that we were finding that had lots of elevated blood lead level kids, what we were finding was that these families were facing poverty, they were facing crime, they were facing neighborhoods that were not walkable, they were facing drug addiction in their family, and so there were so many other challenges that were happening. And so from a public health standpoint, I think population health, it's so important to start in the clinical setting, but I think you have to move beyond that setting to look at what the patients are actually experiencing in their daily lives, because until you start facing those issues and facing them directly, I think that you're not going to make a difference in some of the chronic conditions that they're facing.
So it's always difficult following a biostatistician when you're talking about population health. I will do my best. I mean, when I think population health, I go back to the triple aim, which we've all heard. Better care for individuals, better health for populations, lower cost or lower cost increases, however you want to describe it. But I think what I heard you say is, when you alluded to sort of the acute care versus ambulatory, it's sort of, okay, what are the tactics and what are the logistical things that healthcare networks need to start doing to make that happen? I'm not sure I have a real concise definition of that. In fact, candidly, I'm not even sure I'm qualified to speak to that. I think I'd rather have physicians and clinicians really speak to that, with an awful lot of input from biostatisticians who can assist. I mean, I guess fundamentally, when you think population health, you think panels of patients or panels of populations, and what is a specific disease class that we're going after? So whether it's diabetes or congestive heart failure, how do we start to do the things that tie us back to the triple aim to make those populations healthier? And maybe that's an overly simplistic answer, but that's essentially what I think of when I hear population health.
Yeah, and I would concur. I think, the dilemma is it depends what aspect you're coming from, and then how you're going to try to solve this. And actually, I saw a chart that somebody presented in our organization yesterday that had 3 layers of different health, and population health was in the middle, but how they defined it was your members you serve. Well, in our organization and then on our value side, that's 37,000 members you serve. Then they went down to the next layer, which was everybody else, which was public health. And to me, those are 2 different solutions you're trying to solve. You have more control over your members because you have a clinically integrated network, the care coordination's happening, and you have control over everybody that's doing those members. When you get into public health, then you get into how are we caring, you have the social aspects, and how are we caring across all organizations? And because those patients potentially are going to Kettering, are going to Premier, are going to independent physician groups, and they're all operating differently and have different levels of what they think their care plan should be. Even though evidence-based should be driving everything, we all know every organization has a different flavor of that. So I really think it gets down to whose definition, what is the audience or the group of consumers you're trying to fix, and then you work on the solutions.
Thanks, Gary. A little bit about me. I work in long-term care. I'm the CIO for a organization that has long-term care around the state and home health and hospice. And so when we look at population health, we're looking really at a whole different kind of population. But it's that whole transitions of care that I think we're all going to be talking about a little bit, is, from the acute care setting into either home or home health or those kinds of settings. How do we keep that information and keep it moving along that continuum and capturing all that information, because it's all important. I guess what I would like to know is how, in your strategic plans, in your organization, how geared are you for population health? Are they talking just those terms, or are they talking more in transitions of care or valued, or on the flip side, just the fact that there's going to be value-based payments models, and how do we react to those? What's the approach going on?
Yes. I was going to say yes to all.
Is that too many questions? Come on, guys.
No. It's, I mean, Steve Motil just came up and gave a really good insight into what we're doing from an analytics standpoint to support a lot of the things that you just said. So we're very much coming at it from a perspective of what's the basic blocking and tackling we need to do within the information systems organization to make sure we're prepared to support all those things you just mentioned. So the different things that Kettering is looking at is certainly care coordination. So Jason Coons, who's sitting over there, who leads the process excellence team, which is all about lean and how do we improve processes across the organization. And Steve mentioned this in his presentation, where we really focused on length of stay. And we know that we have a problem getting patients out of the hospital into skilled nursing facilities. There's a real problem in terms of what that does to our length of stay within the network. So Jason, along with our quality team, has started to do things that hopefully speed that up and allow the care coordination to occur so that people can get out of the hospital and get into the appropriate care setting. So there's no question that those kinds of activities are happening. It's all founded on the analytics that we've built. You know, it was through the analytics that we came to the conclusion, or we had the optics into the problem to say, we need to get on top of this. So it all fits together, hopefully, in the long run, and hopefully it is strategic. Terry Day, the president of Kettering Health Network, last year, at the end of the year, came in front of my whole organization and announced that length of stay was the #1 priority for the network. And we built an analytics platform to support it that allows the care coordination to work, to do the things that need to happen. So it all fits together in that regard. So.
So, you know, and to the quick answer is still yes to all those. All those buzzwords are in the organizational strategy, but I think it's not only is it the technology piece, it's the workflow piece. And, you know, one of the things that we've talked about at Premier, we have Fidelity, which is a big home health. And so it's not only transitioning to the long-term care facilities, but it's how do you utilize the home health aspect of this to treat patients once you discharge them from the facility. And what we've talked about is actually reallocating and reskilling of some of the nurses so that we build up more of our home health labor force, and hopefully in the long term, you know, start reducing in the hospital setting. So it's, you know, trying to figure out from a technology standpoint how you do it, but then also the care coordination, who does the care coordination, who does the follow-up, how do you bring more APNs in and take the load off the physicians. And, you know, at the end of the day, it does get back all into the data. And as most organizations, you know, length of stay is a huge revenue thing. So everybody, you know, we're focusing on that as well. But it's how quickly can you get that patient out into a longer-term care facility or home, but make sure that that readmission doesn't happen.
So as a research institute, we don't have our own patients that we're really concerned about, but in this area, we are trying to develop different types of technologies and tool sets that will help the healthcare community do things more efficiently. We're trying to develop tools that look at how rates of adverse events are changing over time, and how what's going on in one care facility might compare to another, and making sure that we're adjusting things appropriately for the patient mix in those hospitals. We're trying to develop tools for population health management, more from the perspective of identifying where the patients are at risk, where do they live, what are the communities where patients tend to have higher rates of readmissions, higher lengths of stay, higher challenges, so that hospitals can triage their patients either upon admission or as they're being discharged, to make sure that they're getting the proper care from a population standpoint. So we're trying to develop different types of technologies that would aid in this ecosystem.
How far off are some of these tools that you're creating?
So we have one tool that we've worked in collaboration with the Ohio Hospital Association that is mainly focused on how those rates of adverse events are occurring over time. Mainly, these are measures that are consistent with the ARC quality measures and the CMS readmission measures, some of the composite measures. So that tool is actually available at this point, and we are trying to develop a population health module within that, where we've geocoded all that claims data and tried to get that insight out as well. The nice thing is that it's really a census of all inpatient experiences across Ohio, so you can see what's going on in a particular community, even if there are multiple hospitals, multiple providers in that community.
Thank you. Great answers. I know it's all, we keep moving towards a goal, and then the next goal kind of explodes, if you ask me, and it just keeps kind of adding new things on as we try to move into that perfect world of providing the health care. Here's the next question. You guys have been working on meaningful use for several years now with the systems, and I guess how How are you doing? How's your ecosystem with that? Supporting it, continuing it, and just seeing, adding the things you need to add. But my second question is, did the meaningful use standards regs that they set up, are they positioning the system well for population health? Or are there more modules needed to help support a lot of the things you need to do?
I would say, from a meaningful use standpoint, yes. Are we meeting the measures? Yes. Do I think it took steps to get us there? Because I think you got the transitions of care, you got the direct messaging and all the measures, and it basically forced vendors and organizations to put in that technology and providers to accept that technology. So I do think it helped. Do I think it's totally gotten us where we need to get? No. Now, of course, we're also going to start working on phase 3 of it, and that'll probably take us another level. But, from my position, it really kind of felt like we did the work and we forced it in to meet the measures, but have they stuck? I'm not quite positive that's the case.
Yeah, I would just sort of echo what Gary said. I mean, meaningful use, it achieved what it wanted to achieve in terms of driving technology into the organization, right? It succeeded in that regard. But now we have all these silos of information, which aren't doing a real great job of talking to one another. So things like care coordination and okay, Andy Lehman is a patient, how many different systems am I in, and when will all that information come together to give a holistic view of Andy Lehman? We're not there yet, but is meaningful use getting us there? In some ways, I would say yes, but we got a long way to go in that regard. But in terms of driving the change, the sort of cynical side of me said, we took a problem and we threw technology at it. And one thing that we really try and do within Kettering is think about, let's not just identify the problem and throw technology at it. Let's think about what the problem is, let's understand the best way to go about solving the problem, and then let's figure out the way the technology needs to fit into that solution. And in some ways, meaningful use feels like throw technology at it. And I think some of the ramifications that we're seeing out of that are things like, there's people that have invested a lot of money in software which can't even get certified now for meaningful use. Interoperability is a problem because the systems don't talk to one another very well. But I think net, it's a good thing. I think it gets us towards population health because it does begin to capture discrete pieces of data, which then we can go ahead and start to do things with. But it's certainly not the end-all, be-all. So.
I think these guys said everything that I would have. So.
Well, Warren, what do you, when you're looking at all the data that's coming through these claims, is there some piece that you say usually with your team always looking at the data, gosh, I wish we had this? Or, what might be?
Absolutely. So I wish, we leverage information from the Healthcare Cost and Utilization Project. The beauty of that is that it's a census of all claims in the inpatient experience. Now, if we could get to the point where we had interoperable data from the EHRs that was a similar census, that would be a thing of beauty, but we're nowhere close to that. And so what these gentlemen said about interoperability, being able to synthesize the data, have the data systems talk to each other, that really is what meaningful use should be all about. And there are just way too many barriers and silos right now because of which system you're using. And so that's I think the next hurdle. And not only interoperability in terms of data sharing, but also being able to integrate that information into the workflow. So those are critical pieces to getting to true meaningful use. And I think it's going to take time to get there.
Okay. And I'm just going to add from the perspective of long-term care, home health, hospice, is that right now with the mandatory bundles coming for knees and hips, we're looking to say, okay, how can we get that diagnosis at discharge from the hospital, so we know these people are in the bundle. And so that's one of the things that we keep trying to get, and our challenge, as well as now we're trying to get, we have EMRs in our long-term care and our home health and things like that, but we're purchasing transitions of care systems so that we can care for those patients and be the one of choice, hopefully, from some of these hospitals, that health systems, so that we can then show that we can keep the length of stay down and through all those different types of services. So it's just another whole piece of, I think, data that is kind of in the middle, and that interoperability piece is really important. Let's see, I just want to make sure I'm covering, we had like 3 or 4 topics on this panel, and I want to make sure I'm getting to that whole thing. Just one second.
Problem with a paper-based system.
I love it. I should have brought my iPad up. But no, we've covered a lot within that. So I guess one of the things that I kind of pulled on the last panel I did, I said, with everything that we're doing in automation and everything that you have at your hospital, let's say you're not worried about a budget and you're not worried about, resources and all like that. So it's blue sky and it's the limit. What project would be something that you would really want to be working on? What would be, Gary, you're my age, so I'm going to say, Gary, you've worked a long time in this industry. So you're thinking, hey, I worked a long time. I'm not going to live forever. Here's one project I would really love to get to do. And then you guys may be a little bit younger. So you may not. But anyway, just a blue sky moment. What are you thinking?
At the end of the day, blue sky, and if you could, again, get back to standards, it's really getting that interoperability. I mean, if we really are going to get where we need to get, we need to get to that true interoperability. We have, it's not a matter of it's just health systems that we have to worry about anymore. As we've said, we've got CVS Minute Clinics, you've got the Walmarts, you've got the telehealth now. So you have people that can go and get a teledoc visit. But at the end of the day, that's still all siloed data. And then if we're really going to do patient care the way it needs to be, you have to aggregate all that somehow. And we have to figure out how to do that. Now, I don't have the answers how to do that, but if I would say you could put all the money out, we have got to get to this interoperability where you can exchange. A physician that's on a next gen can totally get to the sites that are on an Epic or Cerner.
So how do you think the roadmap looks for that, for the next 10-year roadmap? Is that going to get us?
Smarter than me.
The one they have published from the ONC.
Yeah, I do think, I think they're taking steps to do there, but then I also think there's other hurdles to get there, which of course is the finances, which of course is the security, because if they continue to make it, more that a patient then can get down to a field level, if I want that field to go, but that field not to go, then you're going to make it so cumbersome to get data that what's the point of getting the data as well? So there was a speaker last week at Chime that just talked about technology is not going, and it was a room full of CIOs, technology is not what's going to drive healthcare costs down. There's 3 other factors that are out there that are going to prohibit, we can probably make progress, but technology is not the answer. And I think it's back to what Andy said. When you put technology in and we have people on our side, go to telehealth, go do this, go do that. Technology, you've got to have the operational processes down. And you've got to have the people to do it and willing to do it. And just putting the technology won't solve it.
So, blue sky, this isn't very blue sky, but this is what I think is most important for my division within Kettering, and that is we talk a lot about what we need to work on versus how we do the work. So Kettering has distinct strategies, and those strategies are absolutely dependent on everything that my division does. From a technology standpoint, from a lean and process improvement standpoint, we can't advance those strategies unless we do what we do. And that's what we work on. And I think that sort of gets to your blue sky question, but I'm going to shift it over to the how, because ultimately I think this is more important. How my organization delivers our services is really, really important. And that was such a key thought in what Steve presented earlier on our approach to analytics. It's not, hey, Kettering, what's the population health platform you're going to go deploy? It's foundationally, how are we going to put the organization in a position where, regardless of what we need to do from an analytics standpoint, we can deliver the appropriate services to go do that. And that's what Steve is thinking through, and that's what he presented today, is a really sophisticated approach to how we do what we do. And we're taking that approach across the board. So you look at IT service management. If you're familiar with ITIL, we're very invested in that. If you look at things like project management, we're very invested in that. We're going to get really, really good at the basic blocking and tackling of delivering our services out to the organization. And then whatever comes down the pike, whatever strategies we need to go execute against, we're going to be in a position to execute against those things. And that, to me, is really the blue sky, is creating an organization that is so good at what we do that all these dynamics in healthcare that are going on, all this unpredictability, all this change that's being forced on us, we understand how we're going to deliver against that. And what we deliver then, okay, we'll deal with that as it comes. But as an organization, we're going to be really, really strong at what we do. So that's where we want to get to.
Thank you.
So for me, the blue sky picture would be actually what comes after we achieve interoperability and actually have data platforms that are accessible across many health systems, where we can actually develop technology that identifies, here's a patient that is facing a challenge, and can we find 50 other patients across the country that look like them, and identify what courses of treatment actually worked on those, and do that in real time, and integrate that into the workflow of that physician. So models that identify that if I take this course of treatment, I'm putting my patient at risk, based on evidence gathered from thousands of other patients, and developing those types of analytic tools. That to me is where we ought to be going if we can unlock the potential of interoperability.
Last question around population health. To me, it's going to be a lot working with primary care physicians. And how are you priming them, or maybe they're already ready, but what are you doing to prepare their offices or prepare them to be able to move into this new world?
Yeah, I mean, I think patient-centered medical home is sort of the short answer to that question, which Kettering Physician Network is the employed physician group at Kettering Health Network. And across Kettering Physician Network, you know, the primary care practices are all going through being certified, and most of them have been certified as patient-centered medical homes. You know, I've heard it said before, I'm not sure this is entirely accurate, but it's an interesting way to think about it, that clinical integration networks are just pods of patient-centered medical home primary care practices coming together and working together. So that PCMH in a lot of ways lays the foundation for primary care, the primary care changes that need to occur going forward. So Gary, if you're doing anything different, I'd be interested to hear.
Yeah. No, I think that is the direction. I think the other thing that needs to change is the financial model that the employed physicians get paid at. Because now, I mean, they're paid on RVUs, and that's based off of volume. And, you know, if you're really going to change habits and the way and have them use care coordination, you know, it's more the prevention. And I think the financial model, but they're working on what that might look like.
And then one of the last questions I have is, we have a lot of students here today, and I just want to ask, what kind of skill set are you looking for in your employees? As well, Warren, for you too. What are you looking for? Because we, as the young students are coming up, we really, are excited that they're here and they're going to be a part of all of this information systems management over time, and take our jobs, take our places in HIMSS and the local chapter. So what are you looking for, and what do you think are some really key success factors once they're hired that will make a difference for them?
So I'll just describe the types of capabilities that we have in our group, and then I'll go to the skill sets that I think are really important as well. So as you said, we have about 140 people in my group, and my group is called Advanced Analytics and Health Research, and so we're probably about 2/3 on the analytics side. So that's statisticians and economists and quantitative epidemiologists, computer scientists, database managers, algorithmic developers, architects, developers, that type of thing. And then on the health side, we straddle the fence between healthcare research. So a big area of research is the quality metrics that I was talking about before. We also have done a lot of classic work in public health, mainly in chronic disease epidemiology for CDC and NIH. In terms of the skills, so I've mentioned the different types of career paths that we have in our group, but I would say that one of the independent thinking is really critical, and the ability to communicate both in written form and orally is incredibly important in our world in terms of doing the types of projects that we do.
Great, thank you.
So my leaders have heard me say this probably a million times. When I think about hiring people, I think of it in terms of the 3 C's: character, chemistry, and competency. Your question sort of targeted the competency piece of that, but let me speak to the other 2 for just a minute. At a place like Kettering Health Network, we have a really strong culture. We have very clearly defined values, which we really try to live out. When you go, and I'm speaking to the students now, when you go for interviews and you've targeted an organization that you're interested in, don't underestimate the people sitting across the table talking to you in terms of how they're evaluating you against the values that they're looking for. That's really important. It's not just about show me your technical skills. The character component of this really matters, as does the chemistry component of it, which is how are you going to fit in and work with teams of people? In this day and age, there's no getting around that. And then there is the actual skill set that you need. And for the rest of the folks who maybe used to be students sitting in the room for a minute, if you think about individuals, let's say, who you've worked with in the past, think about some were great to work with, some may not have been great to work with. And when you start to view it through that lens of character, chemistry, and competency, I think in a lot of cases what you find is rarely is it the competency piece that either causes someone to be great or to struggle. Usually it's the character or the chemistry piece, and in a lot of cases it's the chemistry piece. But I always view it through that lens. So I would tell the students, go get your technical skills, if it's a MIS degree, whatever that is. I mean, we're always looking for that. That's always good stuff. I think healthcare, by its nature, is extremely complex, and no one expects an entry-level person to come in and understand the business, so to speak. But from a pure IT perspective, there's certain things that you can go learn from an IT perspective. But don't ever lose sight of character and chemistry as you're going down that path, because I'll tell you, at least from my perspective, if you don't get through the character and chemistry at it, you got no chance convincing me that you should be part of the organization because you're really good at a certain skill set.
Yeah, and I would totally agree with that. It's more around the traits, the chemistry. You just have to understand you're going into an environment that's going through a lot of turmoil, and you have a lot of people that, up until this last 5-10 years have not gone through a change. And change is very difficult to a human being anyway, but when you get people that have been in this, in this field for so long, they feel their world is getting turned upside down. And they don't, they don't understand it. They're scared of it. They have all these outside forces coming in that they just, it's just totally changing, and you have to be able to in some ways, you have to be able to take abuse, but be able to handle that very professionally. And so it's those traits of how do you fit in, how do you think, are you thinking outside the box? The technical, we're expecting you to know the technical aspect of it.
And I think why healthcare's special is that we're not building widgets. We're working with actual human patients. We call them client and residents when they get to this environment where I am, the locations and centers. But it's really a human experience. And so I think everything that they really just gave some really great advice, and that really know who you are and how you present yourself, and know that at the end of the day, you're helping, when you're in IT, you're helping people live the mission close to the patient. And so you need to do everything you can to help that person be able to care for the patient better. So I just think you can't emphasize enough that chemistry and character. So thank you. That's great. So what I'd like to do is open it up for questions, and Scott will have the mic. And please, these guys will have an answer for everything, I'll tell you that.
Oh, there's got to be questions. Come on, hands up.
And until we might, do you mind, because you're odd man out, Warren, I'm sorry. But I find it so interesting. Do you mind sharing a little bit more about your department, how you ended up getting to where you are? And I just think it's interesting to have a biostatistician. I don't run into people like you every day.
Okay.
So
What would you like me to share?
just your background and how you ended up.
So I guess I ended up as a biostatistician sort of by accident. When I was in high school, I was very interested in becoming a physician, and I went to Cornell University, but that's where I wanted to go to school, and you had to apply to a major, and I knew I would not get into the school if I applied to biology, where all the pre-med people were going. So I applied to statistics and biometry, thinking that would be a very narrow set of people who applied to that major. And when I got there were only 7 of us. So I was right. I played the odds, and I got in. And I told my advisor stupidly the first day, hey, I may want to switch to biology. I'm not sure the statistics stuff is for me. He said, why don't you just take a couple of courses, see what it's like? And I did, and I really liked it. I really liked the application of mathematics and sort of computer science to all different types of areas of applied research, and that was something that was fascinating to me. And then I just went on and got my graduate degree at Johns Hopkins, and ended up going out to Battelle in Columbus, Ohio, because it was an opportunity to continue the childhood lead poisoning research that I was doing earlier in my career. And I joined that group as a very entry-level person 22 years ago. I was basically a technical resource working on all sorts of different project teams, and really my job at that point was to just really fit in from a chemistry perspective to the teams I was supporting, and do the best work that I could do. And then I got into some project management and then people management, and now I'm where I am today. So that's my background.
Thanks for joining us today.
Thank you for the invite.
And there is a ton of experience on the stage right now, so any health IT topic, I'm sure they'd be more than happy to answer. We do have a question.
So I think earlier Joyce mentions about the effect that people in IT have on taking care of the patient, and I'm really curious how you have had your IT departments, if you're working in IT, how you make them aware of what happens there, how do they affect the patient care, because there's all of that kind of, I'm in the cubicle, I'm out in the hospital, so how do you cross that bridge?
Well, probably 30-40% of my staff are clinicians' background anyway, so they already have that background. Now, part of the thing that we have to deal with is that may have been 10 years ago, and how they practiced 10 years ago has changed, so they also have to change with the times, even though some of them think they still know how to do it. The technical people, it's one of those, we used to sit at the hospital, and you saw it every day, so it is a challenge especially when you're in a separate location, of how do you keep that in the forefront of everybody's mind of what you're there for, and how do you make an impact? So that is a challenge. And we're struggling with that just as a system as a whole, because we have one system support building that, it's not just technology, everybody's around that, even though they may be dealing with patients, scheduling and all that. So we're looking at ways to bring people from the hospitals more to meetings, to talk about how, whether it's IT, whether it's quality, how they are making an impact at the facilities. We tried to have people go out and spend more time at the hospitals, but then you also have to get the work done, so that's a challenge. So it's really just around those conversations and continuing to drive home of what we do day to day, and how does that meet the goals of the organization.
So part of Kettering's culture is we view the care that we deliver to the patients as sacred work, and that comes out of a strong Christian foundation. The Seventh-day Adventist Church and Kettering Health Network are closely tied together. And that culture, as mentioned before, it really permeates what we do, and we keep that out in front of us all the time. In meetings, we have divisional meetings, regular meetings, whatever it may be. Things like starting meetings off with prayer is completely acceptable, devotions, all those sorts of things. And it's not necessarily being with the patient to directly answer your question, but it creates an environment in which we tie back to the patient, and that's really important for us. And as Gary described, and I think this is part of the result of deploying the EMRs, I think most networks, or many networks, went out to the clinicians and said, hey, come on in and help us do this. So we have a lot of clinicians in our information systems division, but certainly not everybody. So the culture that we're trying to create is for those who maybe didn't come from that environment. Let's keep that out front and make sure people are aware of the fact that ultimately this goes back to the sacred work that we deliver to our patients. Whether we're super effective at, the folks working in the data centers truly connecting to that, it's hard to say, but we certainly try to do that. So.
Next question.
Good afternoon. I'm a clinician by profession. I'm a registered nurse, and I've gotten incidences where the patients, they feel that I spend too much time on the medical records chatting. And based on the fact that we all know that hospitals will be compensated by patient satisfaction, as CIOs, what do you intend to do to help the nurse so that the patient can get the satisfaction that's needed to give us a better outcome?
Sure. So governance within Kettering, to speak to that for a second, because it will get to your question. We have what we refer to as the Clinical and Technology Executive Council, CTEC as we call it, which is chaired by our Chief Nursing Officer, our Chief Quality Officer, the Chief Medical Information Officer, the Chief Nursing Information Officer, as well as other directors on my team sit on that committee. And what that group does is says, okay, here's strategically the things that we're trying to do to improve the patient experience, and what are the technologies that we need to deploy to improve that. So out of that group comes really the priorities that my organization needs to work on that focus on issues like you just described. And it starts to get into things like, what are we going to do with using iPads and handheld devices to allow the clinicians to be in front of the patient more rather than working on the workstation? So you're absolutely right in that patient experience is a huge priority. And at least within Kettering, the mechanism with which we're trying to drive change to make that better involves not just IT sitting off in a corner saying, okay, here's a new technology, let's lob it out there and see if it works, but rather let's get quality, let's get the chief nursing officer, let's get the CNIO, the CMIO, let's get all them together to understand here are those targeted ways in which we think we can apply technology to improve it. So.
Yeah, and I concur with that. We have a CNO and a director of informatics that work very closely with on that specific topic of the nurse and, allowing what can we do to free up the nurse's time to spend with that patient. I think the other thing is, we're at a point and, we all implemented the EMRs. Now you're going back and you're optimizing. And I think, when we implemented the EMRs, we tried to keep that workflow in mind, but at the end of the day, you hear the same thing from physicians. Now all I'm doing is on a keyboard in front of a patient. So what are those workflows or technologies that we can provide that help that workflow? And then it's also, I know Mercy mentioned the bedside, and we have piloted the bedside, and we actually have taken a step back from implementing Epic Bedside because what we found out was the burden was on the nurse. And so we got to figure out another way to provide that device to the patient, but doesn't put the burden on the nurse. So it's at the forefront of our minds because, as you mentioned, your patient sat, but your nursing satisfaction scores are going down.
One of the things that you mentioned is the difficulty in all the technology working together. And I'm a physician in a small clinic in Greenville, Ohio, and I'm wondering if Premier Kettering has ever put a thought process in reaching out to your rural areas. It's amazing that I have many, many patients go to your hospitals, but I've never been called once to even converse about a patient. We've set nothing up between our clinics and the hospitals to help your hospitalists, and just was curious if there's anything like that in the forefront.
I know we're doing some things with Wayne, around telestroke and stuff. Around the physicians, it's really the first communication we follow up with is when business development gets us involved. And as they're out there talking to physician groups or physician offices, and, whether that be through one of the HIEs, through CliniSync, through HealthBridge to help some of those gaps that are occurring, we do that. But IT does not normally go out physician office to do that. So I understand because if you went to a HealthBridge, your solution, you're going to get it from Kettering or you're going to get it from us, the results, regardless of who your patients go to. And so that's the beauty of, what HealthBridge provides. So we are willing to engage physicians, we just don't know them out there.
So from a non-technology perspective, so we're taking a good hard look at putting together a clinical integration network, and we'd love to talk to you about that. And I think that may be part and parcel to your question as far as how do you get closely tied to a health network. So after this, if you want to stop by and give me your card or give me your information, I'll be happy to have one of our folks stop by and chat with you, because I think that's a really good solution for this. And we'd love to talk to you about that.
Next question.
As seniors in the HIT field, what are some of the challenges that you see that we might face as we transition into the work field? And what are some of the tips that you have for overcoming some of these challenges?
Did you say as seniors? Okay. I'm suddenly feeling awfully old. I'll be honest with you, I'm not sure I have a real pat answer to that. I might be able to give you a couple of cliches, but here's what's sort of bubbling through my mind right now, and that is healthcare is really, really complicated stuff. And technology, there's sort of a view that it's a young person's game. And I think there's somewhere in between those two things that people that have a lot of experience associated with healthcare have an awful lot of value to bring. And then how do you marry that with new technology to come up with good solutions? Now, I'm sitting here suddenly questioning whether I understood your question at all. Was that what you meant by seniors?
No, I meant students.
Thank you. All right. Let me. Okay. So even with that thought in mind, the young person's part of the game is still there with technology in terms of understanding how to connect. There's all kinds of studies about millennials and Gen Xers and sort of how they like to deal with things around technology. And healthcare needs to be able to address those different populations, if you will via different technology solutions. So I think there's real value in that. I don't know probably a lot of the things that you may know as it relates to how you're communicating with your friends and apps that you're using and all that kind of stuff. And it may very well bring value into healthcare. From that standpoint, I think there's ways that you can transition in that regard in terms of saying, look, here are things that I can bring to the table that you may not be aware of that may very well be innovative and important. So that's kind of top of mind, although I'm afraid I didn't give you a very good answer, but that's kind of top of mind.
So as we bring on new people straight out of either graduate school or an undergraduate program, one of the first things I tell them is that 95 to 98% of the problems that I see in the workforce where something falls apart is because of either a failure of communication or misaligned expectations in terms of what you're planning on doing versus what somebody who is responsible for your work is expecting out of you. And so I really do think that the chemistry, the culture, the communication, the being part of a team are really important, and just managing your own expectations in terms of what your role is going to be on the team, versus what you may have thought while you were going to college, because I think sometimes there are differences between what you thought your career, the path that you thought your career was going to take, and what the realities are of what your new employer is going to really need for you to focus on.
And I just think, the biggest barrier you're going to face is coming into a healthcare organization is understanding the workflows. And again, if you have the right traits, you're going to pick those up. But the acronyms, just the nuances, that's why our clinicians, some of our staff think we should only have clinicians in IT because they don't think if a clinician, if they're a non-clinician, they're not going to understand any of the workflows. Well, I don't believe that because I think if you have the right aptitude, you can pick that up. But I think that would be the biggest barrier you're going to face to begin with.
All right, several questions here in the back. Yeah.
Good afternoon. This is related to cyber attacks. Very recently, the CIA director's personal information was hacked. And what kind of measures the healthcare industry is going to take care in preventing these kind of attacks on patient and medical records?
So we have a whole team that's all they focus on, and we have multiple tools in place. Now, as I've told our board, I'm never going to stand in front of them and tell them I'm 100% convinced that we will never be hacked or attacked. But all you can do is continue to progress, work with your vendor partners on the tools out there, and do the best you can. If somebody says what keeps you up at night, security is one of those things that keeps you up at night, because it's not just about the technology. I mean, it's the employees that are careless with their machines. All of our laptops are encrypted, thankfully, because we've had several instances lately where we've had employees that have, had their laptops stolen out of their vehicles. But that's the thing that keeps, one of the many things that keep me up at night.
Yeah, this is obviously a big deal. At least within Kettering, we have an initiative underway which is looking at things like data loss prevention, server hardening, endpoint protection. I mean, all those kinds of security measures that we need to have in place, we are actively pursuing. And we have in place now. It's just how do you continue to make them better and better. I think it's really interesting, though, that the big weakness is typically, and I think Gary alluded to this, it typically comes back to people. So the phishing schemes that go on, those are amazingly successful to get people to go somewhere and enter their personal information. So we are constantly trying to educate the workforce on don't do that. And we will literally do our own phishing expedition across the network, where we will just send out test emails to see who responds, just to get a sense as to, okay, how's the education working? But that's a huge, huge issue that we face. And education is a really, really big component of that. Because as soon as one person goes out and says, either here's my username and password into the network, or here's personal information, we start to open the door for all kinds of security risks. So I think between education and then sort of that core technology that we're trying to put in place around those different areas, whether it's the data centers or the endpoints, those are all things that we're trying to do to deal with that. But I totally echo Gary's thoughts. This is one that keeps me up at night.
Yeah, and I'll take this opportunity to plug the CSOHIMSS Spring Conference, which is going to focus on cybersecurity and HIPAA privacy security. So if you can't sleep at night, take that opportunity to log on late at night and register for the Spring Conference. So, we do have a question here in the back.
I had a question around the disruption journey that we've been on in IT. Let's say we go back about 5-6 years with the start of Epic, and then looking at today with disruption, and then 5 years from now. Where do you think it was at its high point, and where do you think we're going to be going as far as overall for the whole network?
It's interesting you use the word disruption with Epic. I think many of our physicians would agree with that thought, because the disruption that has occurred in putting the EMR in a lot of ways, and one of the speakers alluded to it earlier, I can't recall who, that anyone who thought that moving to an EMR was a productivity improvement is dead wrong. It's not at all. It's all about trying to capture information and hopefully being a quality improvement. So we've lost a lot of productivity, which is interesting because if you think about a lot of the technology disruption that's occurred across many different industries, typically it's around productivity improvements, or it's around faster or more convenient. And the EMR is not that. And certainly if you talk to some of the older physicians who really sort of had their workflows down in the paper world, they feel like they've lost huge amounts of productivity by going to the EMR. So from a disruptive standpoint, don't assume in that question that the word disruptive means suddenly we're so much more productive, okay? So when I hear your question, then it gets to, have we gotten through the learning curve where the EMR is truly adopted in a way which at least it's being effective? And I think we're starting to see that. Through the optimization efforts of the EMR, that's occurring. We're getting better at making it more usable. Southwest Ohio obviously is a big part of the Epic world, and Epic is doing a lot in terms of trying to make it more usable, and then our analysts within my organization are doing things to make it more usable. So I think it's getting a lot better in that regard. Now, 4 or 5 years down the road, what does that look like? I think the question that was asked earlier about how do you get the EMR and the user to work in a way where the user just isn't staring at, the user just isn't staring at the screen all the time and they're actually in front of the patient. We hear that a lot, and how can we overcome that obstacle? I'm not sure I have a great answer to that, other than when you go to Epic, for example, and you go to their big user group meeting, they're investing an awful lot of resources into handheld and trying to do things so that the clinician isn't tied to the workstation in the room. And I think we'll see really good improvements of that coming down the pike. But step one, in my mind, was get used to at least using an EMR, and that was an awfully big hurdle to overcome.
Yeah, I think, yes, from the EMR technology, I think, yeah, we probably have seen the big disruption. I think there's still going to be pockets, but I think the disruption now is more in the workflows. And again, how do physicians and how do clinicians and organizations deal with the retail space getting in here? How do you then continue on the whole continuum of care to the long term? And that's a different shift. That's not technology, but that's just a different shift of how we've treated patients and consumers in the past.
We do have two more questions, so we'll.
Well, I just want to make a comment. I've been in this business a long time, 20 years in the acute care space, and 10 in the last long-term care. But I'm sorry, you said the last 6 years of disruption. That was meaningful use, and they brought money, which probably a lot of vendors think that's when it started. But we've been in healthcare for a long time, and that's pretty much, for me, a steady state where it's been, is that you were always trying to get the order entry implemented without the best system at the time. And so you were doing a lot of things all the time. But the last 6 years with meaningful use, I agree, that's been probably a challenge. But I don't think in healthcare that's ever going to go away.
A question about data security. Since healthcare has basically not been networked to the extent that other industries have, for instance, banking has had ATM networks for better than 30 years, some industries have standard practices, particularly with data warehousing. For instance, in banking, very often a customer's name appears nowhere in a data warehouse. You actually have to go to an external data warehouse to look up a pseudonym to actually get back to live data on a customer. However, in healthcare data, it seems that very often patients are commingled directly with their live information rather than being obfuscated in some way in healthcare. With the lack of attacks going over 30 years over network-based things, do you see healthcare picking up security practices from other industries that may have been subject to data attacks far longer than the typical healthcare organization?
Yeah, absolutely. I think that, so we dropped the EMRs in over the last 6 years, and candidly, I'm not sure that in meaningful use, there was enough consideration given to the security aspects of dropping these EMRs in. And I think that looking to outside industries, and banking is a perfect example of it, in terms of the rigor around their security, we can certainly borrow things from that. I think that would be extremely beneficial. As I mentioned, when we look at security within my organization, we are really actively trying to do things to make it more secure. And it feels like we're playing catch up to other industries in a lot of ways in that regard. I've heard a lot lately, and maybe you guys have heard this too, where the patient information is now viewed as more valuable on the black markets than credit card information is. So there's a real sense of we have got to secure this data, and we're doing things to move it in the right direction. But for example, the banking industry, I am sure there are best practices out there that we should be looking at. I think that would be a very, very good thing, I guess. It's just a short answer to your question. I think it makes a lot of sense.
But I would say even with that, even in the banking industry and all, I haven't personally, but somebody in my family, again, it's de-identified data, but it's all based off routing and account numbers and all that. And even if you went to a national patient identifier number, those are the things that still get hacked. And if you have that, whatever key piece of information is to get in, then you can get to that information. And so I agree, from a patient name and all that standpoint, that's too visible out there. and we need to get to some other de-identified key element. But right now, that's all we have to tie these systems together. And so until we get to more of a national de-identifiable code, I'm not sure when we'll get there, but I agree with Andy, we got to go off of what the best practices are at these other industries that have been doing it longer than we have.
So I was going to say, I think that, it extends beyond patient records before I answer your question. So I do think that there are concerns about people hacking into devices like insulin pumps and pacemakers and so forth. And that is another type of data security that I think that the healthcare industry is facing today. From Battelle, we manage or co-manage multiple national energy laboratories. We have a big research enterprise, and so we actually face, hacking attempts on a daily basis, like thousands of hacking attempts on a daily basis in terms of the networks that we have to protect. And it is a big part of our business is cybersecurity for the assets that we manage, and it's a big part of the business that we do. And so we have, at least in terms of the work that we do in our analytics space in healthcare, we actually have developed our sort of HIPAA-compliant, FISMA-compliant computing centers based off of what we've done in the national security realm. And so, we have tried to leverage those lessons learned in other industries.